Dr. Javi, it's good to actually have you. Even I'm from Kerala, and ESC Hospital is very close to my birthplace, actually, in Kochi. So it's
Okay.
good to see you on screen over here.
All right.
Uh, I think we are live, so we'll start with the session without any further delay. A very good evening to everyone who have joined in today. On behalf of our team, I'm delighted to welcome you all to our academic discussion for today. As we all are aware, hypertension in India presents as a growing challenge with its prevalence compounded by comorbidities like diabetes and obesity, which further complicates its management. The need of the hour, therefore, would be development of stronger and evidence-based management guidelines that can address the complexities of this hypertension and ease its management in Indians. So for today, we are discussing on the ESC updates, the latest guidelines shared by the ESC, particularly in the Indian context. So I'm thrilled to invite you all for the session of ours, and I'm equally pleasured and to introduce to all of you our distinguished speaker for today, Dr. Jabir Abdullah Gutti. Dr. Jabir is a senior consultant cardiologist and director of academic affairs and clinical research at the Lisi Hospital in Kochi. He has made a significant contributions in cardiology, and we're incredibly fortunate to have such a knowledgeable and inspiring individual among us today to navigate us through the ESC guidelines. So I think we are all looking forward for this insightful session. So without any further ado, I'll hand over the session to Dr. Jabi. So the session is all yours from here.
All right. So could you unshare? I can
Yes,
share.
yes, it is. It is.
So first of all, let me thank the MacLeods and you people to give me this opportunity to have an interaction with the people who are watching. Probably, I think they may be physicians across India. Who are the audience, Anuja?
I think, Ritik, I think you'll be able to guide us.
Doctor, we have physicians and general practitioners from all across the country who are attending this session,
So
sir.
it's an extremely important topic for them, the hypertension, which is the most important killer disease across the world and aptly called as the silent killer. And a large number of people in India are hypertensive. It is close to 20 to 25% of the adult Indian population have been found are considered have hypertension. And the problem is the detection, the awareness, the treatment, and the control is quite dismal in India. The last major epidemiological studies have shown that the proper control of blood pressure occurs in only almost 8 to 10% of Indian population. And treatment is only taken by less than 50% of the people who are found to have hypertension. So it's a major public health problem in India, and the recently published European guidelines have some changes when compared to the previous guidelines regarding the diagnosis, evaluation, and management. So we'll be taking some part of the diagnosis, those areas where there is some change from the previous guidelines and compare it to the Indian scenario. So for measuring blood pressure, no doubt you should have a properly calibrated measurement. We have two types of measurements. One is the common office blood pressure measurement, where the patient comes to the office, where clinician or his staff takes the blood pressure. And then the out of office blood pressure measurement, that is either a home blood pressure measurement by the patient or his relative using a calibrated blood pressure apparatus. Mostly these are digital apparatus, rather than the oscillometric or the previous mercury sphygmomanometers. Now what we use is most of the time what we use is the digital blood pressure apparatus, which should be properly calibrated. So a large number of people may have these things, especially after the COVID era. They may have the pulse oximeter as well as the blood pressure apparatus at their home. So either a home blood pressure monitoring or ambulatory blood pressure monitoring. So for diagnostic purposes, it's recommended, the out-of-office blood pressure is recommended because a significant number of people may have white coat hypertension because they'll have a high blood pressure when the physician takes the blood pressure. And when they go home and if you check their blood pressure at home, it will be normal. Or masked hypertension in the hospital, when the clinician checks the blood pressure, it is normal. And at home, it is elevated. Both are problematic things, especially the masked hypertension, because they may not get the proper treatment. So automated BP apparatus is the rule of the day now. And whenever you check the blood pressure in hypertensives, always check during the follow-up as well as after starting drug. Always look for a fall in blood pressure on standing. That is, look for orthostatic hypotension. That's a 20 millimeter fall after standing for 3 minutes, or that is systolic blood pressure, or a 10 millimeter diastolic blood pressure fall at 3 minutes of standing. This should be performed after the patient is first lying or sitting for 5 minutes. So in blood pressure, it is not a blood pressure alone that is going to create problems. It is the total cardiovascular risk of the patient. So you have to look up many things like the blood pressure, presence or absence of diabetes, CKD, lipid status, coronary artery disease, a lot many things, and also cardiovascular disease, hypertension-mediated organ damage. So a risk-based approach is recommended in the treatment of hypertensives, and irrespective of the age, individual with elevated blood pressure and a score 2 or score 2 OP CVD risk of more than 10% at increased risk of CVD for the purpose of risk-based management of their elevated blood pressure, which is class 1. That means everybody accepts that it is useful and it should be followed. And for diabetes, currently it is the score 2 diabetes, that is the scoring system that the Europeans uses. Pregnancy-related complications like gestational diabetes, pregnancy-induced hypertension, preterm delivery, preeclampsia, stillbirths, recurrent miscarriages are all sex-specific risk modifiers that should be considered up to classify individuals with elevated blood pressure and borderline elevated cardiovascular disease risk somewhere between 5 and 10%. So in a female, you may consider the pregnancy-related issues, especially preeclampsia and recurrent miscarriage. South Asian ethnicity, family history of premature onset of atherosclerotic cardiovascular disease, socioeconomic deprivation, autoimmune inflammatory disorders, HIV, and severe mental illness are risk modifiers that is shared by both the sexes. And this also should be considered to upclassify individuals with elevated BP and borderline cardiovascular. So those with the cardiovascular disease risk of 5 to 10%. So these 5 to 10% risk of 10-year cardiovascular disease risk, you have to take into consideration of pregnancy-related issues in females, and for both the sexes, families with premature cardiovascular disease, socioeconomic deprivation, the ethnicity, South Asian ethnicity, that and also inflammatory diseases. South Asian ethnicity is a high risk for cardiovascular disease. And after assessing the 10-year predicted cardiovascular disease and the non-traditional cardiovascular disease risk modifiers, a risk-based BP lowering treatment decision remains uncertain for individuals with elevated BP, measuring the calcium score, carotid or femoral plaque using ultrasound, high sensitivity cardiac troponin or BNP, or arterial stiffness using the pulse wave velocity. These may be considered to improve risk stratification. That is all class 2B. Many people may not agree to that, but there are some people who believe that it is good. It is not a strong indication, but a plus or minus indication. So using calcium score or carotid or femoral plaques and use of other using other non-traditional risk factors. The opportunistic, that means when you get an opportunity to check a person's blood pressure, in less than 40 years, the patient should get a blood pressure checked in every 3 years if it's found to be normal. And for those above the age of 40 years, it should be once in a year. So those patients with a blood pressure which do not require a treatment or do not currently meet risk thresholds for BP lowering treatment, a repeat blood pressure measurement and risk assessment within 1 year should be considered. Then there are many other types of screening for hypertension, the systematic screening, cell screening, the staff, non-physician screening, health checkups, a lot of things, medical camps. And in any patient with increased cardiovascular disease risk, and when the screening of his blood pressure is between 120 to 139 millimeters of mercury or 70 to 89 millimeters of mercury, it is recommended. This is the high normal blood pressure current. That is a change from the previous recommendations to measure blood pressure out of office using either ABPM, ambulatory blood pressure monitoring, or home blood pressure monitoring, or repeated office blood pressure measurements. So in resistant hypertension, you have to look for adherence to the therapy, either by directly observed treatment or looking for drugs in their blood or urine, whether they are really taking the drugs or not. In CKD, moderate to severe, repeat measurements of renal function test and assessment of eGFR and urine ACR, at least albumin creatinine ratio, at least once a year. That is a class 1 indication. Coronary calcium score, it is class 2B, so it's a plus or minus indication. If it is in patients with hypertension, if the attending physician feels that it is likely to change the patient management. And those with resistant blood pressure should be referred to specialized or hypertension clinics for further evaluation and management. So look for secondary hypertension. Any clinical feature suggesting secondary hypertension, like patient with obstructive features of obstructive sleep apnea, pyrotoxicosis, patients with clinical features suggestive of pheochromocytoma, labile blood pressure, postural hypotension, or some peripheral findings of pheochromocytoma. Those with a renal bruit, renal artery stenosis. So all these things should be checked. Look at the clinical features of secondary hypertension, features of Cushing syndrome, features of hyperaldosteronism. So check for these features, and if there is any clinical suspicion, they should be worked up for secondary hypertension, especially younger patients, or those patients presenting for the first time with target organ damage and really uncontrolled blood pressure. Screening for primary hyperaldosteronism by renin-aldosterone by plasma renin and aldosterone measurement should be considered in all adults with a confirmed hypertension. Now it's a class 2A indication. So in all adults, you have to look at the plasma. This was not mandatory before. Now it's a class 2 indication. 2A indication means most of the people feel that it should be done and it's beneficial. So it's plasma renin by aldosterone ratio. So those patients with a family history of hypertension, opportunistic, their blood pressure should be checked for better to predict the chance of development of adult hypertension. And restrict free sugar consumption. Sugar sweetened beverages to a maximum of 10% of the energy intake. And also, it should be consumption of sugar sweetened beverages should be discouraged, especially soft drinks and fruit juices starting at a young age, so that they should it should be a part of their lifestyle, and they should follow it throughout their life. Those without moderate or advanced CKD, and those with a high daily sodium intake, and increase in the potassium intake of up to 1 gram per day, either by replacing sodium salt with a potassium enriched salt, which contains 25% potassium chloride and 75% sodium chloride, or through diet rich in fruits and vegetables. So a potassium-rich diet in those patients without CKD. Those with CKD or who are taking potassium-sparing diuretics, RAS inhibitors, you should monitor the potassium levels. And when to take the blood pressure medication? Most convenient time for the patient. It is not previously we thought that one drug should be taken at least at night, or it is if the patient is taking more than 2 drugs, one should be taken mandatorily at this during night or before after dinner. It's not like that now. Whichever is the convenient time for the patient, only thing is you should adhere to the treatment rather than looking at the time for medication or medication intake. So in patients with elevated BP and a low medium cardiovascular disease risk, BP lowering lifestyle measures is recommended and can reduce the risk of cardiovascular disease. And sufficiently high CVD risk, if the blood pressure is not controlled after 3 months of lifestyle modification, pharmacological treatment should be taken if the blood pressure remains more than 130/80 at the end of 3 months of lifestyle modification. In those with a confirmed blood pressure of more than 140/90, irrespective of the cardiovascular disease risk, lifestyle measures and pharmacological BP lowering treatment is initiated promptly to reduce cardiovascular disease risk. Now it's a class 1 recommendation. It's not like previous. If you have a confirmed, if the patient has a confirmed blood pressure of more than 140/90 without a cardiovascular, irrespective of the cardiovascular disease risk, lifestyle modification and pharmacological treatment to reduce the cardiovascular disease risk, because European Society have now changed the goal of blood pressure treatment to a blood pressure of 120/139. Secondary hypertension, comprehensive screening in adults diagnosed with hypertension before the age of 40 years, except for obese young adults, where it is recommended to start with obstructive sleep apnea evaluation. Younger patients, the score 2 risk is not validated. So screening for hypertension-mediated organ damage may be considered in young individuals with elevated BP without other increased cardiovascular risk conditions to identify additional individuals for possible medical treatment. So hypertension-mediated organ damage should be looked at. So in all pregnant women, after with the concurrence from the obstetrician, low to moderate exercise, intensity exercise. In pregnancy, when they come with high blood pressure, either home blood pressure monitoring or ambulatory blood pressure monitoring to confirm the high blood pressure. Older and frail patients, those older patients, but less than 85 years, who are not moderately severely frail, their guidelines is same for the younger people. For those above the age of 85 years and with severe or moderate frailty, calcium channel blockers, long-acting calcium channel blockers, or RAS inhibitors should be considered, followed by a low-dose diuretic if tolerated, but preferably not a beta blocker in those above the age of 85 years and frail patients. So moderate to severe frailty, the safety and efficacy of the blood pressure treatment we do not know, and the clinician should consider screening older adults for frailty using clinical tests. Frail patients' health priorities and shared decision approach should be considered when. So frailty is an important question. Is your patient frail? There are scoring systems. There are methods by which, objective methods by which we can classify the frailty. So mild frailty, severe frailty, that influences the treatment. So in elderly patients who are frail, less aggressive management is the rule. So if the BP drops with progressive frailty, deep prescription of the BP lowering medications may be considered. Orthostatic hypotension should be checked before starting the blood pressure treatment and at every time of review. First line treatment for orthostatic hypotension is non-pharmacological approach. Switch BP lowering medications that can worsen the orthostatic hypotension, especially the centrally acting agents, alpha blockers, to alternative agents, and not to simply de-intensify the therapy. Those with CKD, severe CKD and EGFR of more than 20, SGLT2 inhibitors are recommended to improve outcomes in the context of modest. The blood pressure reduction is close to 4 millimeters of mercury systolic. So those with pre-diabetes or obesity, when their blood pressure is more than 140/90 consistently, or the office blood pressure measurement is 130/139 or 80/89, and the patient is predicted cardiovascular disease risk is more than 10%. BP lowering drug treatment is required if the blood pressure remains elevated despite a lifestyle modification for 3 months. History of aortic stenosis and regurgitation who require beta blocker, BP lowering therapy, RAS inhibitors is the first agent that should be considered. So with aortic stenosis or regurgitation, and if you need a blood pressure lowering agent, it is RAS blockers. For the mitral regurgitation also, RAS blocker is the first line antihypertensive agent. So motivational interviewing, all these things, and home BP measurement by using self-monitored blood pressure is recommended to achieve the blood pressure control. So to achieve the blood pressure control, there should be a great initiative, or the patients also should be motivated. And they should also take an active part in monitoring their blood pressure regularly at home or from a clinic, adhering to the drug treatment, adhering to the lifestyle modification. So the key takeaways from the ESC 2024, systolic blood pressure of 120/129 is the goal. So you have to reduce the blood pressure to that level in a hypertensive if possible. And elevated BP category 120/139 and 70/89. This is a new category known as elevated blood pressure. and sociocultural and biological sex as important factors in hypertension. So pursue a systolic blood pressure of 120 to 129, so less than 130 among adults receiving BP lowering medication. Previously, it was less than 140, 90, and in younger patients, try, if possible, if tolerate, less than 130 over 80. Now it is definitely less than systolic blood pressure less than 130. And for accuracy, it should be monitored with out-of-office blood pressure measurement. So now shifting from the previous two-step approach, first reduce to less than 140, 90, then if tolerated, try to reduce it to less than 130, 80. Now the goal is to less than 130, that is 120 to 129 systolic. In those in whom such a tight blood pressure control is not perceived, it could be due to intolerance or the other existence of conditions that favor leniency. There, try to achieve a blood pressure as low as possible, reasonably achievable, the lowest blood pressure reasonably achievable. And tailor the treatment in respect to frailty and older age. And revised guidelines require class 1 recommendations for drugs or procedures to demonstrate direct benefits on actual cardiovascular events, not just BP reduction. So drugs which can reduce the cardiovascular events. In the Indian phenotype, our blood pressure prevalence is high. We develop high hypertension at a younger age group, and a large number of Indian hypertensives are younger patients. And we have greater genetic susceptibility to type 2 diabetes mellitus, presence of abdominal obesity, reduce low HDL cholesterol, increased triglyceride, increased small triglyceride. So all of these things together, the Indian hypertensive patients are at high risk of cardiovascular disease, or they are genetically prone for a higher cardiovascular disease, and the risk is more in younger adults. When we compare to the Western population, our cardiovascular disease occurs at 10 years younger when compared to the Western population. In Asians, the salt intake is high, the salt sensitivity high, sodium circulating is high, sympathetic activity high. And so morning and nocturnal hypertension, there can be nocturnal hypertension with BP variability. The problem of such an aggressive blood pressure control to 120 to 29, is it possible in India? Problem, poor follow-up, inertia from the patients, and the lack of awareness, and lack of education, lack of availability of the resources in large number of rural areas, because in India, large number of people lives in the rural areas where the medical facilities are less, and also the cost of medical therapy. Adherence depends upon how motivated they are regarding the treatment of hypertension, because hypertension mostly is an asymptomatic disease. That's why it's very difficult to treat patients. You have to convince them that you don't have symptoms, but your blood pressure is high. You have to take these drugs for a longer period of time to get a benefit. To convince an asymptomatic patient to take drug for a long time is extremely difficult. And focus on salt reduction, yoga, lifestyle intervention, exercise, the diet, weight loss, physical activity. Our guidelines are of generalized approach, and the global guidelines individualistic approach, especially with the cardiovascular risk assessment objectively with score risk. In Asians, higher prevalence of CVD related to hypertension, increased salt sensitivity, high salt intake, morning surge and early morning or nocturnal hypertension, masked hypertension, mild obesity, behavioral and dietary changes. So these are the problems, because as an ethnic group, we are at high risk of developing cardiovascular disease, high risk of developing diabetes and hypertension, high risk of developing hypertension, and hypertension with diabetes is a deadly rule. So then there is a need for local adaptation of the global guidelines. We cannot, blindly follow the European guidelines, because as an ethnic group and our socioeconomic, socio-cultural background is totally different. We should have guidelines to suit India's demographic and socioeconomic context. And there should be an integrated approach combining both perspectives for a better hypertension control. I'm sure these newer guidelines gives an insight, understanding, and an idea about how patients should be evaluated, managed to get the best possible cardiovascular outcome. Everything in this guideline may not be applicable in the Indian population, but a large number of things are applicable in the Indian population, and even adoption of small things in only the class 1 indications will translate into a great clinical benefit. Thank you.
Thank you, Dr. Javeer, for delivering such a comprehensive and insightful presentation of the extensive ESC guideline. And I think it must have been much more easier for all of us to understand and implement in the clinical practice, particularly based on your for sharing your clinical practice experiences as well. So, Dr. Javeer, we actually have few questions from the audience. So, shall we take it?
Please.
Yes. So the very first question is, in the 2024 ESC update, while the hypertension definition remains at greater than 140/90, the thresholds have been lowered to less than 120/70, which is more in line with the AHA guidelines. So what is its relevance in the Indian population?
If you want to assess the relevance in the Indian population, we also should have a proper epidemiological data, and also the impact of this treatment, the most aggressive treatment to 120 to 129 showing a clinical benefit in terms of reduction in cardiovascular outcomes. We don't have such data with us. All the data available is with the Western population. Because of the previous trials like a sprint trial and those other trials where they looked at very aggressive blood pressure controls, there was some problems, but by and large, there were benefits also, especially in patients regarding, especially towards the stroke endpoints. So the American guidelines went ahead. Actually, they were far ahead of the European guidelines regarding this aggressive, diagnosis of hypertension. Their diagnosis of hypertension is now anything above 140 or 90 millimeters of mercury is a stage 2 hypertension. The European last guidelines, which came after the American ACC AHA guideline, still they use the previous criteria of high normal blood pressure, stage 1, stage 2 blood pressure and all. But this time they have really changed. They also are going into the aggressive pathway. This is because of the large-scale evidence which is available across the world in the form of randomized controlled trials and registry data or real-world evidence, which shows that aggressive control of blood pressure whenever possible is producing clinical benefits. So now the goal is to less than 120 or 229. In the Indian context, I think this is much more relevant because our risk is much more higher than the Westerners' risk because of the younger population. So they tolerate the drugs very well. High chance of diabetes, higher incidence or prevalence of diabetes, high prevalence of cardiovascular disease. So the very aggressive treatment of hypertension to this level, I think it is more useful in the Indian population than the Western population because of our higher cardiovascular disease risk.
Rightly said, Doctor. Thank you very much. The second question aligns with your prior answer as well. Dr. Krishnan has asked, there are recommendations for stricter BP targets for certain high-risk populations in the ESC 2024. So how should clinicians approach management, considering that the Indians have a higher prevalence of metabolic syndrome and associated complications?
I think this we have already discussed. We need an aggressive blood pressure control. And this is one thing. Diabetes and hypertension, we can show it to the patient. Look, your blood pressure was this thing. You have to reduce to this thing. And with drug treatment, look, your blood pressure have come down. Diabetes also, your sugar was this thing, your HbA1c was this. Now with treatment, it has come down. Only thing is they should be convinced that these strict control is going to help them in the long run in terms of reduction in the cardiovascular events. So no doubt, as Dr. Krishnan has mentioned, we are high-risk population, higher chance of metabolic syndrome, higher chance of cardiovascular diseases. Our population requires very aggressive treatment.
Thank you, Dr. Javeer. The next question, I think, again, you partly answered it during your session as well. Dr. Anand asks, a considerable fraction of hypertensives present with organ damage. So what are the caveats in management?
So those patients, when they have organ damage at the time of presentation itself, I always prefer to look for a secondary. These patients should be worked up for at least look for certain common causes of secondary hypertension, like plasma renin-aldosterone ratio to rule out aldosteronism, obstructive sleep apnea, renal artery stenosis, CKD. So they should be worked for common causes of secondary hypertension. Second, these are people who require the most aggressive therapy and to keep, if possible, the blood pressure towards the level of 120 to 129. And depending upon the risk stratification, they should be started on drugs which suits them as per their, depending upon the target organ damage, to reduce the cardiovascular disease risk and to reduce the renal disease, the renal risk also. Both the risk should be reduced. So it must be an individualized therapy, but these are the patients who requires the most aggressive therapy, not only hypertension therapy alone, but also all the other risk factors modification, including the lipid, diabetes, obesity, everything. So it's a comprehensive treatment, not the blood pressure alone.
Rightly said.
So those with target organ damage are at the highest risk.
Yeah. So I think Dr. Anand must have got his answers. We have Dr. Harisha asking, how common is secondary hypertension in Indian patients and who should be screened for the same?
Very uncommon, maybe 5 to 7% of total hypertensives may have secondary hypertension. So by and large, when you see a hypertension, it is most likely a primary hypertension. Secondary hypertension, who should be screened? One, those patients who present with a very high blood pressure at the first time. Those patients, when they present with a high blood pressure, they have the target organ damage. Extremes of age, patients with less than 40 years, high blood pressure, target organ damage. First-time blood pressure detection after 70 years or 65 years of age. Then certain peripheral findings, features of secondary hypertension. Patients with hypertension, postural hypotension. Patients with hypertension and skin problems or NEVI, other things are. That is neurofibromatosis suggest associations with a pheochromocytoma. Patients with hypokalemia and hypertension. And the patients with this absence of pulse in one limb or absence of pulse in the lower limbs and bounding pulses of the carotids. It could be a coarctation of aorta. Patients with the asymmetry of pulses and carotid bruit or carotidodynia, Takayasu's disease. Patient who is obese, short neck, severe snoring, increased daytime sleepiness. Think of obstructive sleep apnea leading to hypertension. Patients with a renal bruit, renal artery stenosis, peripheral arterial disease with hypertension. Look for a renal bruit. So it can be a renal artery stenosis. So these are the patients where there is a clinical clue towards a secondary hypertension. So extremes of age, at the presentation itself, target organ damage, difficult to control blood pressure, resistant hypertension, clinical clue towards a secondary hypertension. These are the groups who should be worked on.
Thank you, Dr. Jabir. I think we'll take the last question for the day. Dr. Abhijit asks, what would be the preferred score to assess and stratify cardiovascular risk among Indian patients with hypertension? So I think we've discussed on score. Yes, sir.
In fact, we don't have. Score is not validated in the people whose age is less than 40 years. And score is basically for European population. But we don't have any other risk, so we may use that. It is not validated in the Indian patients. It's not fully applicable to the Indian patients.
Okay, Dr. Jabir, I think that would be it. So that is all. That's all the questions we had for today. So once again, thank you, Dr. Jabir, for the insightful session and also for your expert understanding, along coupled with the practical solutions and the invaluable sessions you have provided us today. And I think I'll thank all the participants also for having joined us today to make these discussions truly valuable. Lastly, I would like to thank Ritik and the team of Doc Mode for having hosted us so well. So thank you, Dr. Jabir. Have a great evening.
Thank you. Thank you.
Thank you, sir.